Okay, let's unpack this. When you hear heart failure, what immediately comes to mind? For many, it's probably a dramatic image of a heart that's just stopped, right? But the reality, as we're about to discover, is far more nuanced, incredibly complex, and frankly, pretty fascinating. Understanding it on a deep level can fundamentally change how you perceive cardiovascular health. Today, we're not just scratching the surface, we're embarking on a truly comprehensive exploration of heart failure. We'll be focusing intensively on its pathophysiology, the how and why it goes wrong, and its diagnosis. Our mission, really, is to gain a mastery level understanding, like the elite professionals in this field. We're going to dive into every concept and every topic presented in Chapter 257, ensuring you walk away with a profound grasp of this vital area.
And what's truly fascinating here and essential for that kind of mastery level understanding is just how many intricate layers there are. We're talking about a condition that touches the lives of millions globally. This isn't just about the heart feeling in a simple, straightforward sense. No, it's a profoundly complex clinical syndrome. It has widespread implications that ripple across the entire body. Our goal today is to really connect all those dots for you, showing how the heart's struggle impacts seemingly distant organ systems and how this whole cascade of events leads to the symptoms and signs we observe.
And to achieve that deep, comprehensive understanding, we're drawing from a meticulously crafted source. Chapter 257, this isn't a quick summary. It's a true deep dive into the what, how, and why of heart failure, straight from the experts. So let's begin by laying down the foundational definitions. Okay, here's where it gets really interesting right from the start. A common misconception about heart failure is that it's always about fluid buildup, always congestive. But we're moving beyond that older term, congestive heart failure. The real insight here, the critical distinction, is that not every patient shows those telltale signs of volume overload. So why is this shift in terminology so important? What does it reveal about the condition itself?
That's a crucial point you're highlighting. The move away from congestive heart failure to simply heart failure is because, well, precisely as you said, not all patients present with overt signs of fluid overload or congestion. The American College of Cardiology Foundation, the American Heart Association, and the Heart Failure Society of America, the ACC-FAHA and HFSA guidelines, they define heart failure as a complex clinical syndrome. It's a condition that results from any structural or functional impairment of the heart's ability to fill with blood or its ability to eject blood effectively. And this impairment, critically, leads to a specific set of cardinal manifestations. Dyspnea, which is shortness of breath.
Right, shortness of breath.
Fatigue, that profound tiredness, and fluid retention.
Next.
The European Society of Cardiology, or ESC, offers a very similar definition. But it slightly emphasizes the typical symptoms like breathlessness, ankle swelling, and fatigue alongside physical signs. Things like elevated jugular venous pressure, the visible bulging of the neck veins, or crackling sounds in the lungs and swelling of the limbs. These are all caused by an underlying structural or functional cardiac abnormality, which then results in either a reduced amount of blood being pumped out by the heart, what we call reduced cardiac output, or elevated pressures inside the heart chambers, whether the patient is at rest or under stress. So the key takeaway is that heart failure captures a broader, more nuanced spectrum of the disease. And it's also important for that mastery level understanding to clarify the relationship between heart failure and other terms you might hear, like cardiomyopathy and left ventricular dysfunction, for instance. These are more general terms. They describe disorders of the heart muscle structure or function, like a damaged or weakened muscle. These conditions can certainly lead to heart failure, but they aren't heart failure itself. Heart failure is the clinical syndrome that develops when these underlying problems become severe enough to cause symptoms.
That makes perfect sense. So this broader definition means we're looking at more than just one static problem. It also means we need to distinguish between long-standing chronic issues and sudden acute crises. For our listeners aiming for that mastery, what does it mean to differentiate chronic from acute heart failure?
It's a fundamental distinction, yeah, for both understanding and managing the condition. We categorize heart failure into chronic and acute forms. Chronic heart failure describes patients who've been experiencing the symptoms and or signs of HF for a long period. We're talking months to years. These individuals are typically managed with ongoing long-term medical therapies and sometimes device therapies like pacemakers or defibrillators to support their heart function.
Right, the long haul.
Exactly. Acute heart failure, AHF, on the other hand, used to be called acute decompensated HF. It refers to a rapid onset or a sudden severe worsening of existing HF symptoms. Imagine someone who's been managing their condition for years and then suddenly they just can't breathe or their swelling becomes overwhelming. That's often an acute exacerbation. Most AHF episodes are indeed a worsening of existing chronic heart failure, but it's crucial to know that about 20% of acute heart failure cases are actually new onset.
Oh, wow. So first time experiencing it.
Yes, meaning the patient hasn't been diagnosed with HF before and the symptoms strike suddenly. These new onset cases can be triggered by a number of acute cardiac events. Things like an acute coronary syndrome, which is basically a heart attack, or acute valvular dysfunction, a sudden problem with a heart valve, or even hypertensive urgency, where blood pressure spikes dramatically and dangerously high. Sometimes it can also happen as a postcardiotomy syndrome, referring to complications after heart surgery. And within acute heart failure, there's a particularly severe scenario known as acute pulmonary edema in heart failure. This is characterized by rapidly worsening signs and symptoms of pulmonary congestion, almost always due to a severe elevation of left heart filling pressure. It's a real medical emergency where the lungs essentially fill with fluid.
That sounds incredibly serious. So this isn't just a clinical definition we're talking about. It's a major global health challenge affecting millions. What do the numbers tell us about the sheer scale of this problem? Who's most affected, and are we making any progress?
The scale of heart failure is truly staggering, and the numbers really underscore its global impact. Globally, over 26 million people are affected. That makes it a pervasive condition worldwide. In the United States alone, an estimated 6.2 million adults are currently being treated for HF. And get this, more than 600,000 new cases are diagnosed every single year.
Every year?
Yeah. What's particularly striking and important for understanding the demographic shift is how significantly the prevalence of HF increases with age. For individuals aged 40 to 59 years, the prevalence is relatively low, maybe 1–2%, but this dramatically rises to up to 12% in adults over 80 years old. If you look at the lifetime risk of developing heart failure, say at age 55, it's about 33% for men and 28% for women. These aren't small percentages, right? They highlight how common this condition becomes as populations age.
Definitely not small.
And the projections for the United States are also, well, sobering. The prevalence of HF is set to increase by a substantial 46% from 2012 to 2030. That's a massive public health challenge ahead.
Okay, so prevalence is rising. What about hospitalizations? Are more people ending up in the hospital?
That's where it gets interesting. Data from 1980 to 2000 showed a steady rise in HF hospitalizations in the U.S., hitting about 1 million per year. But a fascinating trend emerged more recently. From 2006 to 2016, there was actually a promising decrease from over 1 million admissions down to around 809,000.
A decrease, but you just said prevalence is rising. How does that work?
Exactly. It presents a bit of a paradox. While the prevalence of HFFS, the total number of people living with it, continues to rise, largely due to an aging population and better survival rates, the incidence, the rate of new cases, may actually be decreasing slightly. This is likely thanks to improved recognition, more effective treatment of underlying cardiovascular diseases like hypertension, and better prevention strategies overall. But, and this is a significant warning note for the future, as global rates of obesity continue to climb, these favorable trends in HF incidence might unfortunately reverse. The rising tide of metabolic syndrome and related conditions could lead to a resurgence in new HF cases down the line.
That's a crucial caveat. And are there differences across different groups?
Yes, absolutely. We observe distinct racial and ethnic differences in HF epidemiology, incidence, and hospitalization rates. Studies consistently show higher rates for Black men, followed by Black women, then white men and white women. These disparities are complex, attributed to a combination of factors, including differences in risk factors like obesity, hypertension, and diabetes, socioeconomic status, and, unfortunately, disparities in access to quality healthcare. Interestingly, in emerging nations, as they undergo socioeconomic development and lifestyle shifts, the epidemiology of heart failure is starting to mirror that of Western countries. We're seeing coronary artery disease becoming the most common cause, rather than infectious causes like rheumatic heart disease that were historically more prevalent there.
That paints a really clear, somewhat stark picture of the scale of the problem. What does this mean for someone actually living with heart failure day to day? And beyond the human costs, what about the immense economic ripple effects?
Well, for individuals diagnosed with heart failure, the prognosis, despite improvements, remains quite challenging. In primary care settings, the overall 5-year survival rate after an HF diagnosis is still only about 50%. And for patients with severe heart failure, the 1-year mortality can be as high as 40%. It's serious. In the United States, heart failure is listed on the death certificate for 1 in every 8 deaths. The majority of these patients ultimately succumb to cardiovascular causes, most commonly either progressive heart failure itself or sudden cardiac death. We also know that a number of clinical and laboratory parameters, which we'll dig into later, serve as independent predictors of mortality, helping clinicians assess individual patient risk.
And hospitalizations seem like a huge part of the experience.
They really are. Hospitalizations are an incredibly common and defining feature of the HF patient journey. A large population-based study revealed that a staggering 83% of diagnosed HF patients were hospitalized at least once, and 67% were hospitalized at least twice, 54% 3 times, 43% 4 or more times. It's a revolving door for many. The mortality rates after an HF admission are also concerning. They range from 8–14% at 30 days to 26–37% at 1 year, and can be as high as 75% at 5 years. Readmission is also a massive issue, occurring in 20–25% of patients within just 60 days of discharge, and nearly half are readmitted within 6 months. And crucially, with each subsequent admission, the patient's risk of death significantly rises. Consistent with the incidence data, those racial disparities persist in outcomes, with Black individuals experiencing higher case fatality rates compared to white individuals after hospitalization. But despite these stark statistics, there's a vital positive note. The overall prognosis for patients with heart failure is improving. This is largely due to more aggressive treatment of risk factors and the increased adoption of guideline-directed therapies, allowing patients to live longer and hopefully with better quality of life.
It's good there's some positive news there. But beyond the immense human toll, what about the financial strain this puts on healthcare systems? I can only imagine the sheer cost involved.
Oh, the financial burden of heart failure care is indeed immense. It represents one of the largest expenditures in healthcare globally. In the United States, the direct medical costs for heart failure were estimated at $30.7 billion back in 2012 alone. And projections for 2030 show that hospitalization costs specifically for HF will skyrocket to an astonishing $70 billion.
$70 billion. Just for hospitalizations.
Just for hospitalizations. It's an exponential growth that highlights the escalating financial pressure. And what's often overlooked, or maybe harder to quantify, are the indirect costs. These include things like lost work productivity due to illness or premature death, and caregiver burden. These indirect costs can actually equal or even exceed the direct medical costs. Globally, the total economic burden of HF was estimated at $108 billion in 2012, with direct costs making up about 60% of that. And this isn't just an adult problem either. For pediatric patients suffering from acute HF, inpatient costs are estimated at nearly $1 billion annually and are continuing to rise. It's a significant drain on resources across the board, affecting economies and healthcare systems everywhere.
Okay, let's unpack this. Heart failure isn't just a single condition then. It presents in different flavors, you could say, or phenotypes. And crucially, how we categorize them actually dictates the treatment approach. What are these key distinctions and why do they matter so much?
That's a critical point for a mastery-level understanding, absolutely. The most crucial classification of heart failure is based on the left ventricular ejection fraction, or EF. This is basically a measurement of how much blood the left ventricle pumps out with each contraction. It indicates the heart's pumping efficiency.
Right, how well it's squeezing.
Exactly. Approximately half of all HF patients have what's called heart failure with reduced ejection fraction, or HFrEF, pronounced HEF-REF. This means their EF is 40% or less. This is typically what people imagine when they hear heart failure, a weakened, often enlarged heart that just can't pump effectively.
Okay, that's HFrEF. What about the other half?
The other half fall into the category of heart failure with preserved ejection fraction, or HFpEF-HFpEF, where the EF is 50% or greater. Now, this might seem counterintuitive at first. How can the heart be failing if its pumping function seems normal?
Yeah, that sounds contradictory.
It does. But the key here is that while the pumping ability, the systolic function, is preserved, the heart muscle itself has become stiff and less able to relax and fill properly. That's diastolic dysfunction. Imagine a rigid, inflexible balloon versus a stretchy one. Both can hold air, but only one can inflate and deflate easily and efficiently. HFpEF heart is like that stiff balloon.
Ah, okay, so it's a filling problem, not just a pumping problem.
Precisely. And you might remember older terms like systolic heart failure and diastolic heart failure. These are actually less favored now because we recognize that most patients with heart failure, regardless of their EF, exhibit abnormalities in both systolic pumping and diastolic filling function to some degree. Classifying patients by their EF, HFrEF versus HFpEF is absolutely vital. Why? Because these groups differ significantly. They differ in their demographics. HFpEF patients are often older, more likely to be female, and tend to have more comorbidities like hypertension or diabetes. They differ in the types of comorbidities they experience. And most importantly, for treatment, they differ in their response to various therapies. While HFrEF has several well-established life-saving treatments, finding effective therapies for HFpEF has historically been much more challenging, though recent breakthroughs are definitely changing this landscape.
That makes sense. It guides the whole treatment strategy.
Exactly. And the underlying causes of heart failure are also incredibly diverse, ranging from coronary artery disease to issues with the heart muscle itself, the myocardium, the sac around the heart, pericardium, heart valves, even the great vessels. For HFpEF, the diagnosis can be particularly challenging because its symptoms often overlap with non-cardiac conditions like lung disease or obesity. Clinicians have to be really careful to rule out other causes of shortness of breath or fluid retention.
So we have HFrEF and HFpEF as the two main types. But you mentioned earlier there's this fascinating group of patients whose ejection fraction actually recovers, and another sort of intermediate group. What's their story? How do these newer categories fit into our understanding?
Yes, these newer classifications are incredibly important for refining our approach, especially for that elite professional level of understanding you mentioned.
Right.
First, we have HE-free CEF, or heart failure with recovered ejection fraction. This is a specific and, frankly, incredibly hopeful subgroup of patients. They were initially diagnosed with HFrEF, meaning their EF was 40% or less, but with the benefit of guideline-directed medical therapy, they show a rapid or gradual improvement in their ejection fraction right back up into the normal range, meaning 50% or greater. It's a powerful demonstration of the heart's capacity for recovery with the right interventions.
That's amazing. What predicts who might recover like that?
Good question. There are several predictors that suggest a patient might fall into this HE-free CEF category. Things like younger age at diagnosis, a shorter duration of their heart failure, a non-ischemic etiology, meaning their HF wasn't caused by blockages in their coronary arteries, having smaller ventricular volumes to begin with, and the absence of significant myocardial fibrosis, which is scarring in the heart muscle. We often see this type of recovery in specific clinical scenarios, like fulminant myocarditis, which is severe heart muscle inflammation, stress-induced cardiomyopathy, also known as Takotsubo, peripartum cardiomyopathy, which occurs around childbirth, and tachycardia-induced cardiomyopathy, where a persistently fast heart rate damages the heart. It also happens in cases of reversible toxin exposures, maybe certain chemotherapies, immunotherapies, or even excessive alcohol use that's then stopped. Now, despite this impressive EF recovery, it's crucial to understand that many of these patients may still experience symptoms.
Oh, really? Even with a normal EF?
Yes. This can be due to persistent abnormalities in diastolic function, the heart's ability to relax and fill, or something called exercise-induced pulmonary hypertension, where blood pressure in the lungs goes up during exertion. And critically, for patients who become asymptomatic and feel much better, withdrawing their heart failure therapy can actually lead to a recurrence of their HF symptoms and a decrease in their EF again. So continued. Often lifelong management is essential even after recovery. Overall, though, the prognosis for patients with HFE-CEF is definitely superior to that of patients with either persistent HFrEF or HFpEF, which is why it's such an important distinction to make.
Okay, that's HE-free CEF. What about the other group you mentioned, the intermediate one?
Right, that's HFMR-EF, or heart failure with mildly reduced ejection fraction. These are patients with heart failure whose EF falls in an intermediate range, specifically between 40% and 50%. This group presents a unique challenge and honestly a real opportunity for research, as they don't quite fit neatly into either HFrEF or HFpEF. Clinically, they're often considered to have primarily mild systolic dysfunction, a slight weakening of the pump, but they also usually exhibit clear features of diastolic dysfunction, meaning their heart is also a bit stiff and doesn't fill optimally. This group might include patients who started with HFrEF and whose EF improved into this range, or maybe those who initially had preserved EF but experienced a mild decline in their systolic performance over time. The European Society of Cardiology guidelines have specifically identified HFMREF as a separate group. The main reason for this designation is really to stimulate more research into their underlying characteristics, their specific pathophysiology, and ultimately to identify targeted treatments specifically for them. It acknowledges they might have unique needs and responses to therapy.
Okay, so we've defined heart failure, we understand its global scale, and we've categorized its different presentations based on ejection fraction. Super helpful. But what actually causes the heart to fail in the first place? You touched on it, but it seems like it's not always what you might think. Let's dig into the varied and sometimes surprising origins.
The causes of heart failure are indeed quite diverse, and understanding them is absolutely fundamental to prevention and targeted treatment. We can broadly categorize them into acquired disorders, congenital and inherited disorders, and systemic diseases, plus that special category of high-output states.
Okay, let's start with acquired disorders. Those sound like the most common.
They are, especially in developed countries. Coronary artery disease, or CAD, basically blockages in the arteries supplying the heart muscle, is responsible for roughly 2/3 of all HF cases. This is often due to heart attacks, myocardial infarctions that damage the heart muscle permanently. Hypertension, or chronically high blood pressure, is another major player, contributing in up to 75% of cases. The heart just has to work too hard against persistently high resistance, leading to strain and eventually failure. And diabetes mellitus is a significant factor in 10–40% of cases. It not only increases the risk of CAD, but also seems to have direct toxic effects on the heart muscle over time. If we look at population attributable risk, which tells us how much a risk factor contributes to new cases in a population, we see that myocardial infarction and hypertension are the leading risks for men. For women, however, hypertension is the dominant risk, while previous MI accounts for a much smaller percentage. So there are important sex-based differences in the main drivers.
Interesting. What about conditions people are born with or inherit?
Right. Congenital and inherited disorders are increasingly important. We're seeing a growing number of adults living with congenital heart disease, or CHD heart defects present at birth. In the U.S., over 1.4 million adults now live with CHD, actually surpassing the number of children with CHD, thanks to amazing advances in pediatric cardiac care and surgery. Adults with CHD who develop heart failure generally fall into three main groups. Those with uncorrected defects who present late, maybe due to misdiagnosis or lack of access to care. Those who had repairs or palliative surgeries earlier in life but experienced late valvular or ventricular failure down the road. And those with what's called failing single ventricle physiology, where only one main pumping chamber exists. Each of these patients presents really unique anatomical and physiological challenges that profoundly influence their heart failure course.
And inherited heart muscle diseases.
Yes. Inherited cardiomyopathies are increasingly recognized as causes of HF in adults. These include more common conditions like hypertrophic cardiomyopathy, where the heart muscle is abnormally thick, and arrhythmogenic cardiomyopathies, which primarily involve rhythm disturbances and structural changes. They also include rarer heart muscle diseases linked to specific genetic variants in genes like lamin or titin, or associated with muscular dystrophies like Duchenne and even mitochondrial diseases. Most familial cardiomyopathies are inherited in an autosomal dominant fashion. This really underscores the importance of taking a detailed family history and, in some cases, considering clinical genetic testing, as society guidelines now emphasize, to identify potentially at-risk family members.
So beyond heart attacks, high blood pressure, and genetics, what else can lead to HF?
A whole myriad of systemic diseases can lead to heart failure, often with effects both inside and outside the heart. Examples include infiltrative diseases like amyloidosis and sarcoidosis, where abnormal proteins or inflammatory cells deposit in the heart muscle, making it stiff and dysfunctional. Autoimmune disorders like systemic lupus erythematosus, the SLE, and rheumatoid arthritis can also affect the heart. Various infectious diseases such as Chagas disease, common in parts of Latin America, and HIV can directly damage the heart muscle. Drug toxicities, whether from certain chemotherapies, other prescribed medications, or illicit substances like cocaine or methamphetamines, can also directly induce HF. And in many parts of Africa and Asia, rheumatic heart disease resulting from untreated strep throat leading to heart valve damage tragically remains a major cause of HF, particularly among younger populations.
And finally, those high output states you mentioned, where the heart pumps more blood, how does that fit in?
Right, the high output heart failure states. These are unique because they're associated with a high cardiac output and low systemic vascular resistance. The blood vessels are unusually relaxed. It's really important to understand that these conditions very seldom cause heart failure on their own in a completely healthy heart. Instead, they act as precipitating factors. They push a heart that already has some underlying cardiovascular disease or is otherwise vulnerable over the edge into failure. Common examples include chronic severe anemia, especially when hemoglobin levels are very low, say below 8 GDL. This forces the heart to pump much faster and harder to deliver oxygen. Also, large arteriovenous shunts, which are abnormal connections between arteries and veins that bypass the capillaries, severe obesity, severe liver disease, certain chronic lung diseases, myeloproliferative disorders, types of bone marrow cancers, thyrotoxicosis, an overactive thyroid, and even severe vitamin B deficiency known as beriberi.
The key diagnostic importance here is that if these predisposing conditions are considered, for example, in a patient with cirrhosis or end-stage renal disease with an AV fistula for dialysis, or Paget's disease of bone, or a significant nutritional deficiency, the diagnosis and appropriate treatment of high output heart failure can easily be missed. You have to think about the whole picture.
Okay, we've really established what heart failure is and its incredibly diverse origins. Now let's talk about the how does the heart actually change over time once it starts to fail? You said it's not a static problem. It's a dynamic, often progressive process, almost like a vicious cycle that leads to worsening function.
Indeed. Heart failure with reduced ejection fraction, HFrEF, is fundamentally a progressive disease. It tends to get worse over time if it's not effectively treated. It typically begins with what we call an index event. This could be something sudden and dramatic, like an acute myocardial infarction, a heart attack that damages a significant chunk of the heart muscle. Or it could be more gradual, such as what happens with chronic pressure overload, like uncontrolled high blood pressure forcing the heart to constantly strain. Or volume overload, where the heart is continually stretched by too much blood, like you see with leaky valves. It can also stem directly from those inherited genetic cardiomyopathies or congenital heart issues we discussed.
So something triggers it, then what happens?
Following this initial event, the heart undergoes months to years of what we call cardiovascular remodeling. This is where its structure, its shape, and its function literally change in an attempt to adapt to the new stress or injury. What's fascinating, and often kind of misleading for the patient, is that they can remain asymptomatic or only mildly symptomatic for extended periods during this remodeling phase.
Why is that? If the heart is changing, wouldn't you feel it?
You'd think so, but it's due to the initial activation of various compensatory mechanisms. These are the body's attempts to help the failing heart maintain function. However, and this is the cruel paradox of heart failure, while these mechanisms are helpful in the short term, they ironically contribute significantly to the long-term progression of the disease. They essentially set the heart up for further decline down the road.
Okay, so the heart is remodeling. Is it just getting bigger, or is there more to this structural change? What kind of remodeling are we actually talking about, and why is it ultimately so damaging?
Oh, there's definitely much more to it than just getting bigger, and the specific type of remodeling really depends on the type of stress the heart is under. We primarily see two main patterns of ventricular remodeling in response to excessive workload.
Two patterns. Okay.
One pattern is concentric hypertrophy. Here, the heart's muscle walls thicken quite significantly, and its overall mass increases out of proportion to its internal chamber volume. This is an adaptive response that effectively reduces the stress on the wall under conditions of pressure overload, like in chronic hypertension or severe aortic stenosis, where the heart has to push blood through a narrowed valve or against high pressure. Think of it like a bodybuilder's bicep getting thicker and stronger to lift heavy weights. The heart muscle thickens to generate more force against that high resistance.
Okay, thicker walls. What's the other pattern?
By contrast, eccentric hypertrophy involves an increase primarily in the cavity size or volume of the ventricle. The walls stretch out, becoming thinner relative to the increased chamber size. This typically occurs in conditions of volume overload, like aortic or mitral regurgitation, where the heart has to deal with an increased amount of blood flowing back into it with each beat. Here, the chamber stretches and dilates to accommodate that extra volume, much like a balloon being overinflated repeatedly.
So thicker walls versus bigger chambers, but you said both are damaging.
Yes, ultimately. Regardless of whether it's concentric or eccentric, both forms of remodeling share a range of profound changes at the cellular and tissue level that are ultimately damaging in the long run. The increased ventricular mass, in both cases, is accompanied by significant alterations in myocyte biology. That's the biology of the individual heart muscle cells. They struggle to convert electrical signals into a strong, coordinated pump, what we call abnormal excitation-contraction coupling. Their fundamental force-generating machinery, the cross-bridge interaction between actin and myosin, falters. And incredibly, they even reactivate primitive fetal genes, genes normally active only during development in the womb, essentially reverting to an earlier, less mature state in a desperate but ultimately failing attempt to cope with the chronic stress.
Wow, reactivating fetal genes. That's wild.
It is. There's also beta-adrenergic receptor desensitization, meaning the heart becomes less responsive to adrenaline-like signals. Myocyte hypertrophy occurs, where the cells themselves grow larger, often in a disorganized way. And the very proteins that give the cells their structure, the cytoskeletal proteins, become impaired. Beyond the individual cells, the myocardial makeup itself changes. We see myocyte necrosis, cell death, apoptosis, programmed cell death, and even autophagy, where cells essentially digest parts of themselves. The spaces between the cells fill with interstitial and perivascular fibrosis. That's a kind of stiff, non-contractile scar tissue. And there's degradation of the extracellular matrix, which is the crucial scaffolding supporting the cells. All of these contribute to major changes in ventricular geometry. The ventricle becomes more dilated, its walls thin out, it takes on an increased sphericity, becoming more rounded rather than its normal elongated shape, and the capillary muscles that support the heart valves get displaced. This often leads to atrioventricular valve regurgitation leaky valves that further stress the already struggling heart.
So it sounds like a domino effect of negative changes.
Exactly. This entire process becomes that vicious cycle we mentioned. The initial impairment in pump function, coupled with increased wall stress from having to pump harder, plus systemic vasoconstriction, narrowed blood vessels throughout the body, and a loss of the body's helpful neurohormonal adaptation. It all leads to what we call afterload mismatch. Think of it like this. If your heart is a pump, afterload mismatch means it's trying to push blood out, but the resistance in the pipes, the blood vessels, is far too high. Imagine trying to pump water uphill with a weak motor. That relentless struggle then feeds back, stimulating further damage and more remodeling, creating a self-perpetuating cycle of these harmful processes that ultimately results in the progressive clinical worsening of heart failure.
That's a really clear and frankly quite sobering explanation of how HFrEF progresses. But for HFpEF, where the pumping seems preserved, is the remodeling story different? What's going on at that cellular level when the heart seems to be working but it's still failing?
For HFpDF, yes, the remodeling story is indeed less clear, and our understanding of the underlying mechanisms is still actively evolving. But we do know it's distinct from HFrEF in many ways. Original descriptions tended to focus primarily on diastolic dysfunction as the main problem, particularly thinking about older women with hypertension. At the myocyte, or heart muscle cell level, this was often explained by an impaired uptake of cytosolic calcium back into the sarcoplasmic reticulum. That's a critical process for the heart muscle to relax properly after contraction.
Wow.
This impairment was often attributed to reductions in ATP, the cell's energy currency, so the muscle just couldn't relax sufficiently, meaning it couldn't fill properly between beats.
So a relaxation problem, mainly.
That was the initial thinking. However, as we've identified more and more distinct phenotypes or subtypes of HFpEF, it's become apparent that many other pathophysiologic processes are implicated. It's a much more complex picture. These include widespread problems like vascular stiffness, meaning the blood vessels become rigid, increasing the resistance the heart has to pump against. Also renal dysfunction, where the kidneys aren't working optimally. Sodium avidity, where the kidneys hold on to too much salt and water, and metabolic inflammation, often related to regional adiposity, where fat is distributed in the body, which can contribute to low-grade systemic inflammation. Furthermore, cellular-level alterations like oxidative stress, an imbalance between damaging free radicals and protective antioxidants, and impaired nitric oxide signaling, leading to what we call nitrosative stress, may also play a significant role in disease activity by affecting blood vessel relaxation and heart muscle function directly. Understanding these diverse, often systemic mechanisms is really important because it directly informs the development of future targeted therapies for HFpEF, moving beyond just trying to improve relaxation.
So it sounds like the body, in its attempt to help the failing heart, sometimes activates systems that, paradoxically, turn into major problems over the long term. Let's explore these mechanisms of disease progression, these well-intentioned helpers that ultimately become detrimental, like a double-edged sword, right?
That's an excellent way to put it. A double-edged sword is exactly right. And our understanding of this comes from a huge amount of work. Preclinical studies, human observations, and crucially, landmark clinical trials that have definitively shown how therapies designed to attenuate or even reverse these biological processes can be profoundly beneficial for patients.
Okay, so what's the prime example of this kind of mechanism?
One of the most critical is neurohormonal activation, specifically the activation of the sympathetic nervous system, SNS, often called the fight or flight system, and the renin-angiotensin-aldosterone system, RAAS. Initially, in the acute setting, this activation serves a vital purpose. It increases heart rate, constricts blood vessels to boost blood pressure, and enhances cardiac contractility, how strongly the heart squeezes. It also helps the kidneys retain sodium and water. All of this is an immediate attempt to preload the volume of blood returning to the heart and maintain cardiac output, ensuring vital organs get enough blood flow.
Seems helpful at first glance.
It is, in the short term. However, over time, these unchecked compensatory responses become highly deleterious, really harmful. They lead to excessive vasoconstriction throughout the body, further volume retention, electrolyte imbalances, kidney problems, and baroreceptor dysfunction, which messes up the body's ability to regulate blood pressure properly. They also have direct myocardial toxicity. They directly damage the heart muscle cells themselves and can trigger dangerous cardiac arrhythmias or irregular heartbeats. At the tissue level, this continuous neurohormonal activation contributes significantly to the harmful remodeling of not only the heart but also blood vessels, leading to accelerated atherosclerosis, and it impacts the kidneys and other organs. This whole cascade ultimately drives the development of symptomatic heart failure and its ongoing progression.
But there's good news here, right? We have treatments for this.
Absolutely. This is where some of the biggest leaps in treatment have come from. Landmark clinical trials have definitively shown that antagonizing or blocking the RAAS and SNS with medications, things like renin-angiotensin system inhibitors, ACE inhibitors, ARBs, mineralocorticoid receptor antagonists like spironolactone and beta blockers, can effectively attenuate or even reverse this ventricular and vascular remodeling. And this leads to significant reductions in both morbidity, sickness, hospitalizations, and mortality death for patients, especially those with HFrEF.
Okay, so while some hormones like adrenaline and angiotensin are ultimately bad in the long run, are there also good ones? Perhaps counter-regulatory hormones trying to fight back against this relentless decline? It sounds like a chemical tug of war happening inside the body.
Absolutely. And this is where the body's physiology gets really clever, or tries to be. The body does attempt to counter-regulate. It releases a whole different set of hormones that exert beneficial effects on the heart, the kidneys, and the vasculature. These include the natriuretic peptides you probably heard of, ANP, atrial natriuretic peptide, and BNP, beta natriuretic peptide, as well as prostaglandins, bradykinin, adrenomedulin, and nitric oxide.
Natriuretic peptides, BNP. I know that gets measured in blood tests.
Exactly. ANP and BNP are particularly important. They're stored and primarily released from the atria and ventricles, respectively, in response to increased stretch or pressure within the heart chambers. Think of them as the heart's own internal warning system and relief mechanism rolled into one. Their beneficial actions are mediated through stimulating an enzyme called guanylate cyclase. This leads to systemic and pulmonary vasodilation, relaxing blood vessels, increased excretion of sodium and water by the kidneys, acting like natural diuretics. Inhibition of renin and aldosterone, directly counteracting the harmful RAAS, and modulation of baroreceptors to help regulate blood pressure. They do a lot of good things. It's also interesting to note, therapeutically, that bradykinin and these natriuretic peptides are inactivated by an enzyme called neprilysin. Neprilysin has become a key target for newer therapies like ARNI, which stands for angiotensin receptor neprilysin inhibitor. These drugs block the RAAS and boost the levels of these beneficial peptides by inhibiting neprilysin.
So it works on both sides of the equation.
Precisely. And on the diagnostic front, as you mentioned, measuring levels of these natriuretic peptides, particularly BNP and its precursor NT-proBNP, is extremely useful and widely used clinically to assist in the diagnosis and risk stratification of patients with heart failure.
That's a fascinating balance. What about other, perhaps more subtle chemical signals that might be contributing to the heart's decline? Are there other pathways involved in this progression that we should know about?
Yes. Beyond the major neurohormones and counter-regulatory peptides, other factors definitely contribute to the heart's decline and the progression of HF. Endothelin, for instance, is a potent vasoconstrictor peptide, meaning it narrows blood vessels powerfully, and it also has growth-promoting effects on cells. It seems particularly significant in pulmonary hypertension and right ventricular failure. It's released by various cells in the pulmonary circulation and the heart muscle itself in response to increased pressure. It directly harms the heart, causing myocyte hypertrophy, muscle cell enlargement, and interstitial fibrosis, scarring. Interestingly, unlike the RAAS and SNS inhibitors, drugs that block endothelin haven't consistently shown to slow the overall progression of clinical heart failure when given systemically, although they are beneficial treatments for pulmonary arterial hypertension, which is a different but related condition.
Okay. What about inflammation? We hear a lot about inflammation in disease.
Right. Inflammatory cytokines, such as tumor necrosis factor alpha, TNFSO, and interleukin-1 beta, IL-1, and reactive oxygen species like superoxide, are also thought to cause or contribute to ventricular remodeling and dysfunction. While their exact primary source isn't always crystal clear, evidence points towards organs like the liver and the gastrointestinal tract as potential sources, especially when they become congested due to the heart failure itself. Unfortunately, the role of specific anti-inflammatory and antioxidant therapies to target these pathways remains unproven in large heart failure trials so far, but it's still a very active area of research to see if dampening this inflammation could be beneficial down the line.
And are there any newer, more novel biological targets that have recently emerged in understanding and treating HF? This is where the cutting edge science really comes into play, right?
Right.
For that mastery level.
Yes, definitely. A really significant breakthrough in recent years has been the emergence of SGLT2 inhibitors. These drugs were initially developed for treating type 2 diabetes mellitus. They target a protein called sodium glucose cotransporter 2, which is located in the kidney's proximal tubules. This protein is responsible for reabsorbing a large amount of filtered glucose from the urine back into the bloodstream. What's truly remarkable is that subsequent large clinical trials focused on cardiovascular disease, including heart failure patients with or without overt diabetes, have shown these agents to be not only safe, but also to have profound beneficial effects on morbidity and mortality. It was a huge finding.
Wow. So a diabetes drug helps heart fail even without diabetes.
That's the million-dollar question everyone's still trying to fully pin down. The precise mechanisms are likely multifactorial and are still being intensely studied. Are their benefits primarily due to their mild diuretic effects? Or do they have direct positive effects on cardiac and vascular remodeling? Do they reduce arrhythmia risk, improve renal function, alter metabolic function in the heart, reduce inflammation? It's probably a complex combination of several of these actions that makes them so uniquely effective across the spectrum of heart failure. Another interesting pathway, as we dive deeper, involves cyclic guanosine monophosphate, or CGMP. This beneficial signaling pathway is typically downregulated, meaning it's less active, in heart failure, and this contributes to endothelial dysfunction problems with the inner lining of blood vessels. Newer drugs called oral soluble guanylate cyclase stimulators are designed to enhance this CGMP pathway, and in both experimental and clinical settings, they've demonstrated beneficial myocardial and vascular effects, offering another potential avenue for therapy, particularly for certain patient groups.
We've also heard about electrical issues in the heart, things like dysynchrony. How does that connect to heart failure progression? It feels like the problem goes way beyond just the pump itself, maybe into the wiring as well.
That's a perfect analogy. Electrical problems are indeed a significant contributor, confirming that heart failure is not just a plumbing issue, but often an electrical one too. In up to 1/3 of heart failure patients, especially those with HFrDF, disease progression is associated with a prolongation of the QRS interval on their electrocardiogram. That's essentially a widening of the electrical signal that triggers the main pumping chambers, the ventricles, to contract. This indicates electrical dysynchrony, particularly when it takes the form of left bundle branch block, LBBB, or a significant intraventricular conduction delay. This dysynchrony means the different parts of the ventricle contract out of sync, almost fighting against each other, leading to an abnormal, inefficient, uncoordinated squeeze of the heart chambers.
And can we fix that lack of coordination?
Yes, we can, and it makes a big difference for the right patients. We have therapies like cardiac resynchronization therapy, CRT. This involves specialized pacing, usually using leads in both the right and left ventricles, hence biventricular pacing to correct this electrical dysynchrony. CRT has been clearly shown to improve the heart's contractile function, decrease the severity of mitral regurgitation, that leaky valve common in HF, and actually reverse some of the harmful ventricular remodeling. It's a guideline-indicated therapy for symptomatic HFrEF patients who have LBBB on their ECG and are already on good medical therapy, specifically to reduce morbidity and mortality. It's like getting the different sections of the orchestra to play in perfect time again.
Makes sense. Are there other electrical issues to worry about?
Definitely. Other forms of electrical instability also contribute to worsening HF. Atrial fibrillation with inadequate heart rate control and frequent premature ventricular complexes, PVCs. Those extra early heartbeats originating from the ventricles can both exacerbate heart failure. The link between these fast and irregular rhythms and cardiac remodeling affecting both the atria and the ventricles involves factors like increased wall stress, chronic neurohormonal activation, and inflammation. It's also worth noting, and really important, that very frequent PVCs can, on their own, actually cause a cardiomyopathy, a weakening of the heart muscle, purely due to the constant irregular beats. The excellent news here is that this specific type of PVC-induced cardiomyopathy can sometimes be successfully treated, even cured, with catheter ablation, a procedure to eliminate the source of the problematic PVCs.
Wow, so the rhythm itself can cause the failure sometimes.
It absolutely can. And while we're on remodeling and electrical issues, we should briefly touch on secondary mitral regurgitation. A large number of patients with HFrEF develop this leaky mitral valve, not because the valve itself is primarily diseased, but because the heart structure has changed. It's remodeled due to the underlying heart failure. This happens because of distortion in the whole mitral valve apparatus. Reduced contractile force leads to poor leaflet coaptation. They don't meet properly. The ventricle becomes more spherical, the mitral annulus, the ring the valve sits in, stretches, and the left atrium dilates. This worsening regurgitant volume, where blood leaks backward with each beat, contributes directly to HF progression and negatively impacts prognosis. Interrupting this part of the vicious cycle is now a therapeutic target, with some success using transcatheter techniques like MitraClip in carefully selected patients. It just further highlights the complexity and interconnectedness of everything in HF.
Okay, let's unpack this. For that mastery level understanding, we really need to recognize that heart failure isn't just a problem localized to the heart itself. You've hinted at this, but it sounds like it's a truly systemic disease affecting kidneys, liver, lungs, maybe even the gut. How does this systemic interaction play out, and what does it mean for how the body tries to cope, or fails to?
That's a crucial concept to grasp, absolutely. Because while the primary hemodynamic problem in heart failure certainly originates from abnormalities in myocardial function affecting preload, afterload, and contractility, many of the signs and symptoms we actually see in patients are related to end organ failure or dysfunction. The impact on the kidneys, the liver, the lungs, and other systems is profound. It's a complex domino effect spreading from the heart.
And the heart-kidney connection seems particularly important, cardiorenal syndrome.
Extremely important. The interaction between the heart and kidneys is incredibly significant, leading to what we term the cardiorenal syndrome. This complex interplay results in increased circulating volume, worsens HF symptoms, and ultimately contributes significantly to disease progression and poor outcomes. Traditionally, this relationship was viewed pretty much as a straightforward consequence of impaired forward flow. The thinking was, a reduced cardiac output from the failing heart leads to decreased blood flow to the kidneys. This worsens renal function, activates those neurohormonal systems we discussed, like the RAAS, which then leads to more water and sodium retention. The heart isn't pumping enough blood forward, so the kidneys don't get enough flow. They interpret this as a need to conserve fluid, and the whole problem just spirals and gets worse.
Seems logical. Is that the whole story?
Well, that's where emerging evidence has painted a much more nuanced picture, and this is a really key insight for deeper understanding. Renal dysfunction and heart failure is not solely explained by this idea of arterial underfilling. Instead, systemic venous congestion, meaning increased backward pressure in the venous system due to the failing heart, appears to be a major, maybe even dominant operative factor in the development and progression of cardiorenal syndrome. What's fascinating here is that therapies aimed at relieving this venous congestion, like diuretics, are often associated with significant improvement in renal function in HF patients, which is counterintuitive if you only think about forward flow.
So it's the back pressure harming the kidneys, not just lack of flow.
It seems to be a huge part of it. We've seen that increased intra-abdominal pressure, which is very common in right-sided heart failure due to fluid buildup in the abdomen, ascites liver congestion, and a rise in general abdominal congestion, directly correlate with worsening renal dysfunction in patients with decompensating HF. Imagine the kidneys literally being squeezed by the swollen, congested abdomen, physically impairing their function of blood flow. This interaction isn't just confined to the kidneys either. It also involves the liver and spleen, which actively participate in volume regulation in HF through several complex interactive pathways. Splandic congestion, which is congestion in the abdominal organs like the intestines and liver, leads to portal vein distension, the main vein draining these organs. This then activates both hepatorenal and splenorenal reflexes, which in turn induce renal vasoconstriction, basically. Signals from the congested liver and spleen tell the kidneys to clamp down their blood vessels, further worsening kidney function. Therefore, therapies that lead to effective decongestion in heart failure, whether it's aggressive diuretic therapy or even mechanical means like ultrafiltration, don't just reduce overall volume. They also crucially facilitate a decrease in pressure within the abdominal compartment. This combined therapeutic effect, reducing both volume and pressure, is what seems to improve renal function in HF, highlighting just how interconnected these systems truly are. It's not just about the heart in isolation.
This raises a really important question. We've talked about the major organs like kidneys and liver, but could even our gut and the trillions of microbes living within it, the microbiome and those high output states contribute to heart failure? It sounds like a truly fascinating, almost cutting-edge area of research that really challenges our traditional views of HF.
It absolutely is, and it's an exciting frontier in understanding the full picture of heart failure. We've observed for a while that circulating levels of pro-inflammatory cytokines, those signaling molecules of inflammation, are elevated in a number of cardiovascular diseases, including heart failure. And these elevated levels are consistently associated with disease progression and worse outcomes, suggesting that chronic inflammation is a key driver of the disease process. While the primary source of this inflammation hasn't always been clear, emerging evidence now strongly suggests that alterations in the gut microbial composition and a loss of microbial diversity play a significant role.
The gut microbiome affects the heart.
The thinking is that gut congestion, which happens when blood backs up from the failing heart into the veins draining the intestines, coupled with this altered gut microbiome, may propagate a chronic state of low-grade inflammation and immune system dysregulation throughout the body. And this in turn leads to the progression of HFrEF. One potential key player here is lipopolysaccharide, or LPS. This is a component of the cell walls of certain gut bacteria, gram-negative bacteria. Levels of LPS circulating in the blood are found to be increased in heart failure patients, particularly during periods of congestion when there's increased intestinal permeability. Essentially, the gut lining becomes leakier, allowing these bacterial products to escape into the bloodstream. Notably, these LPS levels are often reduced with effective diuretic treatment, suggesting that decongesting the gut can impact this pathway. LPS is a potent stimulator of the immune system and can lead to dysregulated systemic inflammation through macrophage activation. The resulting increases in cytokines like TNF-, IL-1, and IL-6 within these inflammatory pathways can cause a progressive loss of cardiac function and may even contribute to cardiac cachexia, that severe muscle wasting syndrome seen in advanced HF.
Are there other gut-related molecules involved?
Yes. We're also seeing a mechanistic link between the gut microdependent generation of a molecule called trimethylamine oxide, or TMAO. TMAO is derived from specific dietary nutrients like choline and carnitine, which are found in red meat, eggs, and dairy. Certain gut bacteria metabolize these into TMA, which is then converted to TMAO in the liver. Higher levels of TMAO have been linked to poorer outcomes in patients with both acute and chronic heart failure. Furthermore, microbe-generated uremic toxins, such as indoxyl sulfate, may play an important role in HF development and progression, especially in patients who also have kidney problems. So, the powerful conclusion, especially for someone aiming for that elite professional understanding, is that bowel ischemia, lack of blood flow, and/or congestion, depending on the severity of heart failure, can cause significant morphological and functional alterations in the intestines. This can lead to bacterial endotoxemia, like LPS getting into the blood, and a chronic pro-inflammatory state that actually fuels the heart failure progression. It means the gut isn't just a passive bystander, it's an active participant in cardiovascular health and disease.
That's absolutely fascinating. And let's quickly circle back one more time to those high output states we mentioned earlier, things like severe anemia or liver disease. You emphasize they're rarely the sole cause of heart failure, but they act as crucial triggers. What makes them so dangerous when someone already has underlying heart issues?
Exactly right. While the vast majority of heart failure patients, whether they have reduced or preserved ejection fraction, present with low or perhaps normal cardiac output accompanied by elevated systemic vascular resistance. A minority of patients do present with that high output state. This is characterized again by low systemic vascular resistance. The blood vessels are very relaxed or dilated. As we emphasized, high output states by themselves are seldom the sole cause of heart failure in an otherwise healthy heart. You need a pretty extreme state for that. Instead, their development in the presence of underlying cardiovascular disease can precipitate or trigger heart failure, essentially pushing a vulnerable heart over the edge into decompensation. Take chronic severe anemia as a prime example. It's associated with a high cardiac output state when the hemoglobin level drops significantly, typically below 8 grams per deciliter. This happens because the body tries desperately to compensate for the reduced oxygen-carrying capacity. It increases vasodilatory metabolites, causes arteriolar vasodilation, widening of small arteries, and decreases blood viscosity, making it easier to pump. All of these factors contribute to that low systemic vascular resistance and high flow state. However, even severe anemia rarely causes high output heart failure in the complete absence of an underlying cardiac abnormality, like ischemic or valvular heart disease. Patients with end-stage renal disease, for instance, are particularly at risk of developing high-output HF when their chronic anemia is exacerbated by the increased blood flow through an arteriovenous fistula that they might have for dialysis access. This extra volume and flow burden can be enough to decompensate a heart that's already compromised by kidney disease or hypertension.
What are the most common causes of these high output states nowadays?
In contemporary studies looking at patients specifically diagnosed with high-output heart failure, the most common underlying causes observed were obesity, accounting for about 31% of cases, liver disease at 23%, large arteriovenous shunts, often surgically created for dialysis or due to trauma, also at 23%, chronic lung disease at 16%, and mild proliferative disorders at 8%. So while maybe not the most common type of HF overall, these high output states are critical to recognize. Why? Because if you can identify and treat the underlying high output condition, for example, aggressively correcting the severe anemia, treating the liver disease, or closing an unnecessary AV shunt, you can often significantly improve or even resolve the heart failure itself. It's about understanding and managing the entire physiological context.
Okay, we've journeyed through the really complex what and how of heart failure pathophysiology. Amazing detail there. Let's shift now to the crucial next step. How healthcare professionals actually evaluate and diagnose heart failure in a patient presenting with potential symptoms. It seems like it starts with arguably the most fundamental diagnostic tool, simply listening carefully to you, the patient, and your story. What are the key symptoms they're listening for?
Indeed, the patient's history, the story they tell, is absolutely critical. It acts as the initial and often the most revealing diagnostic step. The most common symptoms of heart failure are directly related to that concept of volume overload and the elevated pressures that result in the pulmonary and/or systemic venous systems.
So fluid backing up, essentially.
Exactly. Shortness of breath, or dyspnea, is the cardinal manifestation of left heart failure, especially when fluid backs up into the lungs, causing pulmonary congestion. It can present in different ways. It might start with increasing exertion, like finding it harder to climb stairs or walk uphill. It can develop when lying down flat, which we call orthopnea. That's a classic sign. Patients often need to prop themselves up on multiple pillows to breathe comfortably at night. Or it can awaken a patient suddenly from sleep, gasping for air, known as proximal nocturnal dyspnea, or PND. In advanced stages, dyspnea can even occur at rest, which is obviously very limiting.
What's actually causing that feeling of breathlessness?
It's multifaceted. Pulmonary venous congestion, where fluid builds up in the lungs' blood vessels, leads to fluid leaking out into the lung tissue, interstitium, and air sacs, alveoli. This, in turn, decreases lung compliance, making the lungs stiff and harder to inflate, increases airway resistance, can cause hypoxemia, low blood oxygen levels, and creates a ventilation-perfusion mismatch, where some areas of the lung get air but limited blood flow, or vice versa. Additionally, the stimulation of special nerve receptors in the lungs, called juxtacapillary J receptors, can increase the drive to breathe, making you feel breathless. And reduced blood flow to the respiratory muscles themselves can lead to lactic acidosis, further contributing to that profound sensation of dyspnea.
Clinicians often talk about NYHA class. What is that?
Right. To help categorize patients based on the level of effort required to provoke breathlessness, we use the New York Heart Association, or NYHA, functional classification. It ranges from Class 1 to Class 4. Class I means ordinary physical activity doesn't cause undue fatigue, palpitations, dyspnea, or chest pain. Class 2 means ordinary activity results in symptoms. Class 3 means less than ordinary activity causes symptoms. And Class 3 means symptoms are present even at rest, and any physical activity increases discomfort. However, it's important for listeners aiming for mastery to know that NYHA class is subjective and doesn't always correlate perfectly with objective measures like left ventricular size, ejection fraction, or peak oxygen consumption measured during exercise testing. It's more a reflection of the patient's perceived limitation.
Okay. And you mentioned orthopnea and PND specifically. Can you elaborate on those?
Sure. Orthopnea specifically refers to dyspnea that occurs relatively quickly after a patient lies down flat. This happens primarily because fluid redistributes from the abdomen and lower body up into the chest when you're recumbent. This increases the work of breathing due to decreased lung compliance. Also, if there's significant ascites, fluid in the abdomen, or hepatomegaly in large liver, the diaphragm can be elevated, further compressing the lungs. Orthopnea is typically relieved fairly quickly by raising the head and chest, often by using multiple pillows. In severe HF, patients might even report sleeping sitting upright in a chair. It can also be accompanied by a nocturnal cough due to that pulmonary congestion.
And PND, proximal nocturnal dyspnea.
Paroxysmal nocturnal dyspnea, or PND, is distinct and often more frightening for the patient. It's characterized by episodes of severe shortness of breath and coughing that awaken a patient suddenly from sleep, usually 1 to 3 hours after falling asleep. It's often accompanied by intense anxiety and a feeling of suffocation, forcing them to sit upright or even stand up for relief. Unlike orthopnea, PND is less predictable and may take 30 minutes or longer for the feeling of breathlessness to subside once sitting up. These episodes are frequently accompanied by coughing and wheezing, sometimes termed cardiac asthma, thought to be due to increased pressure in the bronchial arteries, and interstitial pulmonary edema, which increases airway resistance, mimicking traditional asthma. A very severe form of this is acute pulmonary edema, involving marked elevation of pulmonary capillary wedge pressure, causing severe shortness of breath, often with that classic pink, frothy sputum, a true medical emergency.
We also see sleep-related breathing disorders, like chain-stose respiration, that pattern of breathing that waxes and wanes with periods of apnea, and central sleep apnea that can precipitate PND episodes in some HF patients. These seem related to increased sensitivity of the respiratory center to arterial CO2 levels and a prolonged circulatory time from the lungs to the brain. Unlike obstructive sleep apnea, which has treatments like CPAP, central sleep apnea in HF currently has no proven therapy beyond optimizing the heart failure treatment itself.
Okay, those are the classic left-sided failure symptoms. What about right-sided failure, when fluid backs up in the body?
Right. Symptoms of right heart failure are typically related to systemic venous congestion. Initial manifestations usually include weight gain, often the first sign patients notice, and lower extremity edema, swelling in the legs, ankles, and feet. As congestion progresses, patients often experience a range of gastrointestinal symptoms. This is due to edema, or swelling of the bowel wall itself, and also hepatic congestion, the liver becoming swollen with backed up blood. Abdominal bloating, anorexia, loss of appetite, and early satiety, feeling full very quickly after starting to eat, are very common. Some patients may even develop right upper quadrant abdominal pain, often described as an ache or fullness, resulting from the stretching of the liver's capsule. Nausea and vomiting can also occur. When these symptoms are combined with abnormal liver function tests on blood work, it can sometimes lead to a misdiagnosis of gallbladder or other biliary tract disease. In severe refractory, difficult to treat right heart failure, patients can develop massive edema involving the entire body, known as anasarca. Sometimes this is accompanied by recurrent cellulitis, a bacterial skin infection in the swollen lower limbs.
So congestion is key. Beyond that, what about symptoms that point to the heart simply not pumping enough blood forward to meet the body's needs? What does that low output state feel like for the patient?
Right, those are symptoms of reduced perfusion, sometimes called a low output syndrome. Fatigue and weakness, particularly noticed in the lower extremities during or after activity, are very common but admittedly nonspecific symptoms of HF. They can occur with exertion or even be present at rest in more severe cases. It's often described as a profound tiredness that really impacts daily life and quality of life. The pathophysiology here involves reduced blood flow to the exercising muscles, often compounded by endothelial dysfunction, problems with blood vessel lining function, and increased systemic vascular resistance resulting from that chronic neurohormonal activation we talked about. There are also chronic alterations that occur in the skeletal muscle structure and metabolism itself in HF patients, making muscles less efficient and contributing to this fatigue. In older patients with heart failure who also have underlying cerebrovascular disease, reduced systemic perfusion can sometimes manifest neurologically, causing things like mental dullness, a depressed effect, or even confusion. It's really important to remember, though, that while low cardiac output is a key cause of fatigue, it can also stem from other issues, things like volume depletion from overdiuresis, low sodium levels, hyponatremia, unrecognized iron deficiency, or even as a side effect of certain medications like beta blockers, especially when first started. So a careful assessment is always needed to pinpoint the cause of fatigue.
Are there any other less common but still important symptoms?
Yes, beyond these core symptoms, patients with HF may also report mood disturbances like depression or anxiety, which are common comorbidities. Poor sleep is also frequent, often exacerbated by nocturnal dyspnea, orthopnea, or PND, and underlying sleep apnea. Nocturia, or waking up frequently at night to urinate, is common. This happens because lying down improves cardiac output and renal perfusion, leading to increased urine production overnight, essentially a delayed diuretic effect, as the kidneys finally get better blood flow when the patient is resting. Conversely, oliguria, meaning significantly reduced urine output during the day, is usually a sign of very advanced stage HF, reflecting severe reductions in renal blood flow and indicating the kidneys are struggling significantly.
So those are the key symptoms clinicians are listening for, but what causes them to suddenly worsen? Someone might be stable for months, then suddenly decompensate. What are the common triggers for that acute worsening?
That's a critical question for both diagnosis and, perhaps more importantly, for management and patient education. As we mentioned, heart failure patients can often be asymptomatic or only mildly symptomatic for extended periods, either because their underlying cardiac impairment is mild or because their compensatory mechanisms are effectively balancing things out. However, symptoms can rapidly develop or worsen when one or more precipitating factors disrupt this delicate balance, increase the heart's workload, and tip the patient towards acute decompensation. In fact, a specific precipitating factor can be identified in a remarkable 50% to 90% of all hospital admissions for worsening heart failure. So these acute crises often have a clearly identifiable trigger.
So finding that trigger is key. What kinds of things are we talking about?
They fall into several important categories. First, patient-related factors. These include things like unaccustomed excess physical exertion or significant emotional stress. Dietary indiscretion is huge, consuming too much fluid or, very commonly, too much sodium in their diet. Critically, non-adherence with prescribed medications, especially diuretics, is a very frequent cause. And heavy alcohol consumption can also trigger decompensation. Second, provider-related factors. Sometimes the medications that cause salt and water retention, like NSAIDs, ibuprofen, naproxen, are inadvertently recommended or prescribed for other conditions. Or medications with negative inotropic properties, meaning they weaken heart contraction, like certain calcium channel blockers, verapamil, diltiazem, might be prescribed inappropriately. Also, simply unrecognized underlying congestion and inadequate use or dosing of diuretics by the healthcare provider can be a factor in someone decompensating. Third, HF-related disease states. Things like uncontrolled hypertension is a big one, development of myocardial ischemia or a new infarction, heart attack. The onset of new or poorly controlled atrial or ventricular arrhythmias, like rapid atrial fibrillation, or suffering a pulmonary embolism, a blood clot traveling to the lungs. Finally, other systemic disease states can also trigger decompensation. A systemic infection, like pneumonia or a urinary tract infection, puts stress on the whole body. Worsening renal or hepatic failure for other reasons, development of hyperthyroidism, overactive thyroid, untreated obstructive sleep apnea, or the development of significant anemia.
That's a lot of potential triggers.
It is, and it's absolutely critical for clinicians and for patients themselves to try and recognize and promptly correct these factors. Failure to identify and address the trigger can lead to persistent heart failure symptoms despite otherwise seemingly adequate treatment, meaning the patient remains symptomatic, has repeat hospitalizations, and poorer outcomes. Finding and fixing the trigger is paramount.
Okay, so beyond the patient's story, which is clearly vital, a thorough physical examination is paramount. It provides crucial, tangible clues about the severity and type of heart failure. For our listener aiming for mastery, what are clinicians actually observing, listening for, and feeling for during that hands-on exam?
Absolutely. The physical exam is a cornerstone of HF evaluation, offering a wealth of information about the patient's current hemodynamic state, the severity of their condition, and potential clues to the underlying cause. Let's walk through what a clinician systematically observes, listens for, and feels piece by piece.
Okay, starting with just general appearance.
Right. Starting with the general appearance, patients with mild to moderate HF might actually appear well-nourished and quite comfortable at rest. Even those with more advanced disease might seem okay after a few minutes of rest in the exam room, but will often show dyspnea, shortness of breath, with minimal exertion, like just walking from the waiting room or getting onto the exam table. In severe low-output HF, you might see pallor, a paleness often due to associated anemia, or perhaps a dusky complexion indicating poor tissue perfusion. They might have cool extremities and peripheral cyanosis, a bluish discoloration of the fingertips, nail beds, or lips. A significant finding in long-standing severe HF is cardiac cachexia. This is formally defined as unintentional edema-free weight loss of more than 5% over the preceding 12 months. It's often accompanied by a distinct bitemporal hollowing at the temples, or upper body muscle wasting. The contributing factors are complex. Poor oral intake due to anorexia or early satiety, decreased fat absorption because of bowel wall edema, and an underlying catabolic and metabolic imbalance driven by those inflammatory cytokines we discussed, plus dysregulation of the growth hormone insulin-like growth factor 1 pathway. It's a sign of very advanced disease. Rarely, in cases of severe right HF with significant liver congestion, you might even see scleral icterus, yellowing of the whites of the eyes, and jaundice, yellowing of the skin.
Okay, then vital signs. Blood pressure, heart rate.
Exactly. Moving to vital signs. In new onset HF, you'll often see an increased heart rate, tachycardia, and sometimes an initially elevated blood pressure due to that acute sympathetic nervous system activation. However, in patients with chronic HF, who are well managed on guideline-directed medical therapy, the resting heart rate ideally should be controlled, often below 70-75 beats per minute, and their blood pressure should typically be in the normal to low normal range. The rhythm should be noted. An irregular rhythm might indicate atrial fibrillation or flutter, or perhaps frequent premature atrial or ventricular complexes. In severe decompensated HF, signs of low output include hypotension, low blood pressure, a narrow pulse pressure, the difference between systolic and diastolic pressure, and often a rapid, weak, thready pulse. A fascinating and important physical sign, if present, is pulsus alternans. This is where you feel the pulse alternating between strong and weak beats while the rhythm remains regular. It's attributed to reduced left ventricular contraction in every other cardiac cycle, likely due to incomplete recovery, causing an alternation in LV stroke volume. It's a strong indicator of severe LV systolic dysfunction. Respiratory rate is usually normal at rest, but typically increases when the patient lies down or with minimal exertion. Patients with advanced HF may exhibit that periodic breathing or Cheyne-Stokes respirations pattern cycles of deep breathing, followed by shallow breathing or apnea. Often the patient is unaware of this, but family members find it very alarming. Oxygen saturation measured by pulse oximetry is typically normal on room air unless there's acute pulmonary edema, an underlying congenital heart defect with shunting, severe pulmonary arterial hypertension causing right-to-left shunting, or a significant coexisting lung disease. Occasionally, a low-grade fever can be present in severe HF, thought to be due to cytokine activation, and it usually subsides as the patient's condition improves with treatment.
What about the neck veins? I know doctors always look at those. The JVP.
Yes, examination of the jugular venous pulse, or JVP, is crucial. It provides an estimate of the right atrial pressure, which reflects the overall fluid status and the pressures on the right side of the heart. This is typically assessed with the patient reclining at a 45-degree angle. The clinician quantifies the vertical height of the venous pulsation above the sternal angle, adding 5 centimeters to estimate the central venous pressure in CMH2O. In mild right HF, the JVP might actually be normal at rest, say at 8 centimeters 2O, but becomes elevated with sustained 10-15 seconds compression over the liver or upper abdomen. This is called hepatojugular reflex or abdominojugular reflex. It's a very sensitive sign of elevated right-sided filling pressures, even if the resting JVP is normal. In chronic, severe right HF, the JVP can be markedly elevated, with pulsations visibly approaching the angle of the jaw even when sitting upright. If significant tricuspid regurgitation, the valve between the right atrium and ventricle is leaky, is present, you might see prominent V waves and rapid Y descents in the JVP waveform.
The abdominojugular test, when performed properly, can also suggest elevated left-sided filling pressure if the JVP rises significantly during 10 seconds of firm mid-abdominal compression and then drops abruptly on release. A rise in JVP with inspiration, known as Kussmaul's sign, is an ominous finding, typically pointing to severe biventricular HF, or less commonly constrictive pericarditis, a condition where the sac around the heart becomes rigid and restricts filling.
Moving down to the lungs. What are you listening for?
When listening to the lungs with the stethoscope, the classic finding is rales or crackles. These are sounds caused by fluid transudation into the alveoli or small airways. They're usually heard first at the lung bases, but in severe HF or acute pulmonary edema, they can be diffused throughout the lung fields. Sometimes wheezing and raunchy, coarser sounds, can also occur due to congestion of the bronchial mucosa, which can occasionally lead to a misdiagnosis of primary asthma or COPD. This is the so-called cardiac asthma. Interestingly, and importantly, rales might be completely absent in patients with long-standing chronic HF, even if they have chronically elevated pulmonary capillary wedge pressures. This is thought to be due to an increased capacity of the pulmonary lymphatic system to drain away the excess fluid over time. So the absence of rales definitely doesn't rule out significant congestion. Pleural effusions, fluid accumulating in the space between the lung and the chest wall, are also common, particularly in biventricular HF or predominant right HF. They cause dullness when you percuss, tap over that area, and decreased breath sounds when listening.
When effusions are unilateral, they are more often found on the right side for reasons that aren't entirely clear.
And the heart itself. What can you tell from listening and feeling there?
The cardiac examination reveals a lot as well. In chronic HF, with ventricular remodeling, there's often evidence of cardiac enlargement. The apical impulse, the point of maximal impulse, usually felt near the nipple line, may be displaced downward and to the left. It might feel diffuse and weak in dilated cardiomyopathy, or more sustained and forceful in pressure-overloaded states like aortic stenosis or severe hypertension. In patients with significant right ventricular enlargement or severe pulmonary hypertension, often seen in biventricular or severe right HF, a right ventricular heave or parasternal lift may be palpable along the left sternal border. Auscultation, listening with the stethoscope, is key. An S3 gallop, a distinct low-pitched extra-hard sound heard early in diastole, sounding like Kentucky, is very common in HF, with volume overload and tachycardia. Its presence suggests severe hemodynamic compromise and carries a negative prognostic significance, and sometimes palpable as well as audible. An S4 gallop, sounding like Tennessee, heard just before the S1, is not specific to HF, but is often present in HFpEF due to conditions causing a stiff ventricle, like hypertension or aortic stenosis.
Murmurs are very common. Holosystolic, heard throughout systole. Murmurs of mitral and tricuspid regurgitation, leaky valves, are frequent findings in advanced HF, often occurring without primary structural abnormalities of the valves themselves, but rather due to the distortion of the heart chambers and valve apparatus caused by the remodeling process, functional regurgitation. A loud pulmonary component of the second heart sound, P2, suggests the presence of secondary pulmonary hypertension.
And finally, the abdomen and extremities, looking for swelling.
Yes, examining the abdomen and extremities primarily assesses for signs of systemic venous congestion and fluid retention. Hepatomegaly, an enlarged liver, is often an early sign of systemic venous congestion. The liver edge, felt below the right costal margin, might be tender initially due to stretching of the liver capsule, but this tenderness may actually disappear with chronic long-standing congestion. The liver edge may even feel pulsatile in the presence of severe tricuspid regurgitation. Long-standing hepatic congestion can eventually lead to cardiac cirrhosis, with associated congestive splenomegaly, enlarged spleen, and the development of mild to moderate ascites, fluid accumulation in the abdominal cavity. However, if a patient presents with massive ascites, it should prompt a search for other potential causes, like primary constrictive pericarditis or underlying primary liver failure. Lower extremity edema is, of course, a very common finding in chronic HF. It's typically symmetric and pitting, meaning an indentation remains for a short time after pressure is applied to the swollen area.
Chronic edema can lead to secondary skin changes, like stasis dermatitis, reddening, pigmentation, induration, hardening, weeping of fluid, or even recurrent bacterial cellulitis. Anasarca describes massive generalized edema involving not just the legs but also the sacrum, especially in bedbound patients, the abdominal wall, and sometimes even the upper body. Crucially, edema can sometimes be absent, particularly in acute HF or in younger, more ambulatory adults with chronic HF, even if they have markedly elevated systemic venous pressures. So its absence doesn't rule out HF or significant fluid overload. If edema is unilateral, only one leg, it should raise suspicion for other causes like deep venous thrombosis, a blood clot, prior trauma, or vein harvesting for bypass surgery. And if the edema is non-pitting and unresponsive to diuretics, it might represent lymphedema, swelling due to lymphatic system blockage, which requires a different diagnostic workup and treatment approach. The physical exam is truly a masterclass in careful observation and interpretation.
That's an incredibly comprehensive rundown of the physical exam. It really highlights how much you can learn just by looking, listening, and feeling. But beyond what a doctor sees and feels, blood tests and advanced imaging provide deep, often unseen insights into the heart's function and the body's systemic response. What are the key lab tests and initial imaging tools clinicians rely on for diagnosis and evaluation?
They're absolutely essential for comprehensive evaluation, you're right, because the symptoms and signs we just discussed, while crucial, aren't always specific enough or sensitive enough on their own for a definitive diagnosis. Clinicians really need a high index of suspicion, especially in patients who are at higher risk, like older individuals, those with known underlying cardiovascular disease, or those with comorbidities like hypertension, diabetes, and chronic kidney disease. In these situations, additional laboratory testing and imaging are almost always performed to help confirm the diagnosis of HF, assess its severity, identify potential underlying causes or contributing factors, and guide management.
So what's included in that routine lab work?
Routine lab work for a patient being evaluated for heart failure typically includes a comprehensive metabolic panel. This checks electrolytes like sodium, potassium, kidney function markers, BUN, creatinine, glucose, and liver enzymes. A complete blood count, CVC, is done to look for anemia, which can worsen HF or signs of infection. Coagulation studies might be checked, especially if anticoagulation is being considered, and a urinalysis can give clues about kidney function or proteinuria. Depending on the patient's overall clinical profile, targeted screening for diabetes, usually with an HbA1c test, dyslipidemia, cholesterol levels, and thyroid function, TSH, might also be done, as these conditions can both cause and significantly worsen heart failure.
What specific things are you looking for in those results?
Well, renal function markers like BUN, blood urea nitrogen, and creatinine are often elevated in moderate to severe HF. This can be due to reduced blood flow to the kidneys, prerenal azotemia, and/or increased renal venous pressure from congestion. It's also very common for renal function to worsen temporarily when patients are started on diuretics or RAAS inhibitors, or if they take non-cardiac medications like NSAIDs, so careful monitoring is absolutely key. Proteinuria, finding significant protein in the urine, can be a sign of long-standing hypertension or diabetes affecting the kidneys, or sometimes suggest an underlying systemic disease like amyloidosis. Liver function tests may show modest elevations in transaminases, AST, ALT,
alkaline phosphatase, and bilirubin in patients with chronic right HF due to that congestive hepatomegaly we talked about. It's important not to confuse this with primary liver or biliary tract disease. Marked elevations in liver enzymes, especially along with a high lactic acid level, can suggest cardiogenic shock, a very severe state of low cardiac output. Chronic cardiac cirrhosis can lead to hypoalbuminemia, low protein levels in the blood, which can exacerbate fluid retention and sometimes hyperammonemia, which might contribute to altered mental status. Non-specific inflammatory markers like the erythrocyte sedimentation rate, ESR, C-reactive protein, CRP, or uric acid don't usually help specifically diagnose HF, but they can indicate general inflammation, which might be relevant. More specific tests looking for autoimmune diseases like antinuclear antibodies, rheumatoid factor, plasma cell disorders, serum-free light chains, serum protein electrophoresis, iron overload, ferritin iron studies, copper disorders, ceruloplasmin, or infections like hepatitis C or HIV are reserved for targeted testing when the clinical picture suggests one of these underlying conditions might be contributing to the heart failure.
What about electrolytes? You mentioned those can be off.
Yes, electrolyte abnormalities are very common and clinically significant in HF. Hyponatremia or low sodium levels can result from dietary sodium restriction, aggressive diuretic therapy, and also from the body's inappropriate retention of free water mediated by vasopressin, also called antidiuretic hormone. Hyponatremia is generally considered a negative prognostic indicator in HF, predicting decreased long-term survival. Hypokalemia, low potassium, most often occurs as a consequence of using thiazide or loop diuretics without adequate potassium supplementation, or sometimes due to increased aldosterone levels. Conversely, hyperkalemia, hypotassium, can be a significant side effect of RAS inhibitors, ACEs, ARBs, MRAs, or potassium supplements. Both hypo and hyperkalemia are dangerous because they can increase the risk of potentially life-threatening atrial or ventricular arrhythmias. Careful monitoring and management of potassium levels is crucial. Hypophosphatemia, low phosphate, and hypomagnesemia, low magnesium, are also frequently seen, often associated with chronic alcohol use or aggressive diuresis.
And anemia, you mentioned that as a trigger too.
Right. Anemia itself isn't diagnostic of HF, but if present, it can definitely exacerbate symptoms, particularly those related to ischemic heart disease, and guidelines recommend it should generally be corrected if found. As we discussed, only rarely does severe anemia cause high-output HF, and usually only in the presence of some other underlying cardiovascular disease. A related and increasingly recognized issue is iron deficiency, which can occur with or without anemia in chronic HF patients. It's thought to be due to factors like decreased gut absorption of iron, impaired hepatic storage, or chronic low-level blood loss, for example from the gut or from frequent blood draws. Repleting iron stores, usually intravenously, has been shown in clinical trials to improve patients' symptoms, exercise capacity, and quality of life, and importantly, to reduce HF hospitalizations, although a clear effect on survival is still being determined. Screening for iron deficiency is becoming more routine in HF management.
Okay, so we've got the blood work giving us that chemical snapshot. What about initial imaging, like chest x-rays and ECGs? What stories can they tell about the heart structure and electrical activity?
Chest x-rays provide an excellent initial overview and can reveal major abnormalities suggestive of heart failure, although a normal chest x-ray doesn't rule it out, especially in chronic HF. In left heart failure, you might see an enlarged cardiac silhouette, typically defined as a cardiothoracic ratio greater than 0.5, meaning the heart's width takes up more than half the chest width. You might also see signs of pulmonary venous congestion. Early signs of acute HF or worsening congestion include upper zone venous redistribution, where the blood vessels at the top of the lungs become more prominent as blood backs up, and thickening of the interlobular septa, seen as thin horizontal lines near the periphery, called curly B lines, indicating fluid in the lung tissue interstitium. When pulmonary capillary wedge pressure becomes severely elevated, alveolar edema can appear as diffuse haziness or fluffy opacities in the lung fields, essentially representing fluid filling the air sacs. However, a key insight for mastery is that in patients with chronic HF, these classic X-ray findings of congestion might actually be absent despite significantly elevated pulmonary pressures.
This is thought to reflect the increased capacity of the pulmonary lymphatic system to remove excess fluid over time. So clear chest X-ray definitely doesn't rule out chronic congestion or elevated filling pressures. Pleural effusions, fluid collections around the lungs, are common findings in biventricular HF, causing blunting at the costophrenic angles and appearing as layering fluid. They vary in size and distribution, but are often right-sided when unilateral. The chest X-ray is also very useful, of course, for identifying or ruling out alternative non-cardiac causes of dyspnea,
like pneumonia, significant COPD, or lung masses.
And the ECG, what does that tell us?
The electrocardiogram, or ECG, is essential, but it's important to state upfront that no specific ECG pattern is diagnostic of heart failure itself. A normal ECG makes systolic dysfunction less likely, but doesn't rule out HF, especially HFpEF. However, the ECG provides vital information about potential underlying cardiac disease, rhythm disturbances, and factors that influence prognosis and therapy choices. For instance, finding evidence of left ventricular hypertrophy, LVH, and/or left atrial enlargement might suggest underlying HFpEF due to conditions like chronic hypertension, aortic stenosis, or hypertrophic cardiomyopathy. Finding Q waves or other evidence of prior myocardial infarction strongly suggests underlying ischemic heart disease as the cause of the HF. Sometimes you might see Q waves along with reduced QRS voltage, a so-called pseudo-infarct pattern, which can be suggestive of restrictive or infiltrative cardiomyopathies, like cardiac amyloidosis. Finding significant conduction system disease, like high-degree AV block or bundle branch blocks, might raise concern for specific conditions like cardiac sarcoidosis or Chagas cardiomyopathy in the right clinical setting.
Atrial fibrillation, whether paroxysmal, intermittent, or persistent, is found in up to 40% of chronic HF patients and is a crucial finding because it usually indicates the need for anticoagulation to prevent strokes. Finding frequent ventricular ectopi, like premature ventricular complexes, PVCs, and runs of non-sustained ventricular tachycardia, NSVT, can reflect worsening HF hemodynamics and are generally markers of increased risk for sudden cardiac death. Conversely, as we discussed, very frequent PVCs, typically 10–15% of beats, can actually cause irreversible cardiomyopathy, which might be successfully treated with catheter ablation. Lastly, the QRS duration and morphology, specifically the presence or absence of left bundle branch block, LBBB, are critical parameters used to ascertain whether a patient with HFrEF might benefit from cardiac resynchronization therapy, CRT pacing. Hashtag 3.4 Advanced Diagnostics and Invasive Insights.
That's a really deep dive into the initial diagnostic toolkit history, physical, labs, X-ray, ECG. It seems like you can get pretty far with those. But if the basic tests aren't enough to get to the root of the problem, or if the case is particularly complex or severe, what even more powerful imaging techniques and sometimes invasive procedures do clinicians turn to?
That's right. When the initial assessment requires deeper insight, or when specific questions about the underlying cause, etiology, severity, prognosis, or suitability for advanced therapies need answering, we move into more advanced non-invasive imaging and, in select situations, invasive hemodynamic studies or biopsies.
Let's start with the non-invasive imaging. Echo seems like the workhorse.
Absolutely. Non-invasive cardiac imaging is paramount for diagnosis, evaluation, and ongoing management of HF. And two-dimensional echocardiography with Doppler is arguably the single most useful and widely available tool. It's incredibly accurate and rapid. It allows for precise determination of ventricular size, wall thickness, and global and regional function, essentially. How big the chambers are, how thick the walls are, how well they squeeze overall, and if specific areas aren't moving well. It also provides detailed assessment of valvular morphology and function of the valve structure normally. Are they leaky, regurgitation, or narrowed stenosis? It can also readily detect complications like intracavitary thrombi, blood clots inside the heart chambers, or pericardial effusions, fluid around the heart. A key measurement, as we discussed, is the left ventricular ejection fraction, or LVEF. An LVEF of 50% or greater is generally considered normal systolic function. Newer echocardiographic techniques like myocardial strain rate imaging, often using speckle tracking technology, can detect subtle abnormalities in heart muscle deformation, even when EF is normal, adding incremental diagnostic and prognostic value, especially in conditions like HFpEF or cardio-oncology. Doppler techniques are integral to the exam. They allow us to estimate cardiac output, estimate pulmonary artery pressures, calculate valve areas and stenosis, quantify the severity of regurgitation, and critically, detect abnormalities in left ventricular diastolic filling patterns, which is absolutely key in diagnosing HFpEF. In patients with end-stage HF being considered for advanced therapies, echocardiography is critical for assessing right ventricular size and function, which heavily influences outcomes after mechanical circulatory support device implantation or heart transplant. Sometimes a transesophageal echocardiogram, TEE, where the ultrasound probe is passed down the esophagus for clearer views of the heart, is needed. TEE is often used to rule out blood clots in the left atrial appendage before cardioversion for atrial fibrillation, or to get very detailed views of aortic or mitral valve pathology when considering transcatheter replacement or repair procedures.
What about other imaging, like MRI or CT? When do they come into play?
Cardiac magnetic resonance imaging, or CMR, has emerged as a highly accurate and quantitative tool, often considered the gold standard for measuring LV and RV mass, volumes, and ejection fraction, all without using ionizing radiation. Its real strength lies in tissue characterization. Using techniques like late gadolinium enhancement, LGE, CMR is particularly useful for determining specific causes of HF. It can clearly differentiate ischemic cardiomyopathy, damage from heart attacks, showing characteristic scar patterns, from various non-ischemic cardiomyopathies like myocarditis, inflammation, hypertrophic cardiomyopathy, or rhythmogenic cardiomyopathy, or infiltrative diseases like amyloidosis or hemochromatosis, iron overload, or sarcoidosis. For adults with complex congenital heart disease, CMR is exceptionally helpful in defining multiple intricate anatomic and functional abnormalities. Serial CMR studies can also be valuable for quantitatively tracking disease progression or assessing the response to specific treatments over time.
Cardiac computed tomography, or CT, while less utilized for routine functional assessment or tissue characterization compared to echo or CMR, can be very helpful in specific situations. It's excellent for ruling out significant coronary artery disease in lower-risk patients, CT angiography, assessing pericardial disease like calcification and constrictive pericarditis, or clearly visualizing a suspected left ventricular apical thrombus, especially in patients who have implantable devices that interfere with MRI. Cardiac positron emission tomography, or PET, is a more specialized nuclear imaging technique, often limited by availability and cost. Its primary roles in HF include evaluating the extent of myocardial viability, whether scarred heart muscle is still alive and might benefit from revascularization in patients with ischemic cardiomyopathy, and reliably determining the severity and distribution of active cardiac inflammation in suspected cardiac sarcoidosis, where it can guide immunosuppressive therapy.
Okay, that covers the major imaging modalities. Beyond looking at structure and function, what about assessing a patient's functional capacity directly, perhaps with exercise testing, or using specific blood biomarkers beyond the basic labs to help with diagnosis and prognosis?
Absolutely. Both are important parts of the advanced evaluation. Cardiopulmonary exercise testing, CPET, which involves monitoring heart rate, ECG, blood pressure, oxygen uptake, VO2, and carbon dioxide production, VCO2, during graded exercise, typically on a treadmill or bicycle, is not routinely performed in all HF patients. However, it provides a very objective assessment of peak functional capacity, and is particularly crucial for patients being evaluated for advanced therapies like mechanical circulatory support, LVADs, or heart transplant, as the results heavily influence listing decisions and prognosis. Key prognostic parameters derived from CPET include the peak oxygen consumption, peak VO2, and ventilatory efficiency, often measured as the VE-VCO2 slope. Lower peak VO2 and higher VE-VCO2 slope are independent predictors of poorer survival. CPET also provides valuable additional data on the heart rate and blood pressure response to exercise and can unmask exercise-induced arrhythmias. It can also be extremely useful in defining the primary cause of dyspnea, shortness of breath, when the diagnosis is uncertain, helping to differentiate between cardiac limitations, pulmonary limitations, deconditioning, or other causes.
And biomarkers. You mentioned BNP earlier. Are there others?
Right. Biomarkers are incredibly valuable adjunctive tools in the HF diagnostic and prognostic armamentarium. Circulating levels of the natriuretic peptides, specifically BNP and N-terminal proBNP, NT-proBNP, are the most established and widely used. As we discussed, they are released from the atria and ventricles primarily in response to increased myocardial wall stress or stretch. Essentially, they're a biochemical signal that the heart is being overworked or is under pressure. Patients with HF-REF generally tend to have higher levels than those with HF-PES, although there's considerable overlap. Levels can also be falsely low in obese patients, which is an important caveat. Clinically, measuring BNP or NT-proBNP is very useful in ambulatory patients presenting with dyspnea to help support or refute the diagnosis of HF, particularly when there's clinical uncertainty or coexisting lung disease. These levels also provide powerful prognostic information. Higher levels correlate with worse outcomes in patients with established chronic HF.
There's also ongoing research into whether serial measurements might help guide optimal dosing of medical therapy in stable outpatients, biomarker-guided therapy. Though this isn't yet standard practice everywhere, it's critical to remember that many non-cardiac factors can also increase natriuretic peptide levels, including older age, female sex, chronic kidney disease, atrial fibrillation, pulmonary embolism, and pulmonary arterial hypertension. So levels must always be interpreted within the full clinical context. However, a very low BNP or NT-proBNP level can be extremely helpful in excluding heart failure as the primary cause of acute dyspnea, especially in non-obese patients presenting to the emergency department. It has a very high negative predictive value, serving as a powerful rule-out tool, Newer biomarkers like galectin-3 and soluble ST2, SST2, have also been approved by regulatory agencies for providing prognostic assessment in chronic HF, but they haven't yet gained widespread clinical use compared to natriuretic peptides. Other markers reflecting myocardial injury, like high-sensitivity troponins or renal injury, require further study to define their specific roles in routine HF management.
And sometimes, even with all these sophisticated non-invasive tools, we still need to go deeper, right? What about truly invasive studies, actually getting catheters inside the heart chambers? When is that necessary?
Indeed. In specific, often more critical or diagnostically challenging situations, invasive studies are necessary to fully characterize the hemodynamics, confirm a specific diagnosis, or guide complex therapies. In the intensive care unit setting, for example, the placement of a pulmonary artery catheter, POTEC or Swan-Ganz catheter, allows for direct, real-time measurement of cardiac filling pressures, right atrial pressure, pulmonary artery pressure, pulmonary capillary wedge pressure, an estimate of left atrial pressure, and cardiac output, usually by thermodilution. This information is vital for differentiating cardiogenic, heart-related, from non-cardiogenic pulmonary edema, for managing patients with severe hemodynamic instability, like cardiogenic shock, and for titrating vasoactive medications precisely. While used less routinely than in the past, POCIs can still provide invaluable information in complex, critically ill patients when performed and interpreted correctly, usually at the bedside. In the cardiac catheterization laboratory, simultaneous measurement of right and left heart filling pressures during a right and left heart catheterization can be essential for definitively distinguishing certain conditions that can mimic each other clinically, such as restrictive cardiomyopathy versus constrictive pericarditis. These conditions require very different management approaches, so making the correct diagnosis is paramount. Coronary angiography, injecting dye into the coronary arteries, is often indicated during cardiac catheterization, particularly in patients presenting with new-onset HF or unexplained worsening of chronic HF, to definitively exclude significant ischemic heart disease as the underlying, potentially reversible cause of the left ventricular dysfunction. Identifying severe blockages might lead to revascularization procedures like stenting or bypass surgery that could improve heart function and outcomes. If echocardiographic image quality is suboptimal, left ventriculography, injecting dye directly into the left ventricle, can provide an assessment of left ventricular size and global and regional function, and can also help quantify the severity of mitral regurgitation. Finally, the role of right ventricular endomyocardial biopsy, taking several tiny samples of heart muscle tissue, using a catheter inserted through a vein in the overall management of HF, remains somewhat controversial and is reserved for specific indications. These include the detection of acute myocarditis, especially giant cell myocarditis, which requires aggressive immunosuppression, confirming the diagnosis of cardiac amyloidosis or other infiltrative diseases, diagnosing certain chemotherapy-related cardiomyopathies, and importantly, screening for cardiac allograft rejection following a heart transplant. So while invasive and carrying small risks, these studies offer unmatched diagnostic clarity or therapeutic guidance in very specific, complex clinical scenarios.
Okay, so we've gone incredibly deep into the heart itself, its mechanics, its electrical signals, the remodeling process, and the vast array of tools we use to measure its function and diagnose failure. But for that true mastery, that elite professional view, we need to zoom out again, right? You've emphasized that no organ system acts alone. Heart failure seems to be often just one part, albeit a central part, of a larger clinical picture, intricately intertwined with other conditions that affect its course and outcomes. What are the major comorbidities we need to consider, and how do they impact the patient living with heart failure?
That's a profound truth in medicine, particularly with a chronic systemic condition like heart failure. The presence of other medical conditions or comorbidities significantly impacts the development, the progression, the treatment response, and the ultimate outcomes of HF. It makes management much more complex, turning it into a truly systemic challenge. Successfully addressing these comorbidities is often just as crucial, if not more so in some cases, as treating the heart failure itself.
Diabetes seems like a huge one you've mentioned a few times.
It absolutely is. Type 2 diabetes mellitus is not only a major independent risk factor for the development of heart failure, both HFrEF and HFpEF, but it also significantly increases morbidity and mortality in patients who already have established HF. It's highly prevalent in HF cohorts, affecting anywhere from 10% to 40% or even more of ambulatory patients, and the numbers are even higher in hospitalized patients. When diabetes and HF coexist, patients face a substantially heightened risk of adverse outcomes, more hospitalizations, higher mortality, a worse quality of life, and significantly higher healthcare costs. HF is actually now considered a critical cardiovascular outcome in patients with diabetes, underlining just how strong and bidirectional this link is. We've also seen, quite excitingly, that certain glucose-lowering therapies can indeed impact both morbidity and mortality in this population. Most notably, the SGLT2 inhibitors, which we discussed in the pathophysiology section, have been shown to be safe and highly effective in HF patients, improving cardiac and renal function, and significantly decreasing the risk of HF hospitalization and cardiovascular death, regardless of whether the patient actually has diabetes or not. It's a prime example of how managing a comorbidity with the right agent can directly benefit HF outcomes, showcasing the power of understanding these systemic connections. Mechanistically, diabetes adversely affects the heart through multiple pathways, altering myocardial energy substrate use, causing abnormal mitochondrial function, increasing oxidative stress and inflammation, promoting lipotoxicity, impairing insulin signaling and other key pathways, all directly impacting heart muscle structure and function. It also accelerates atherosclerosis.
What about breathing issues during sleep? Sleep apnea.
Sleep apnea is another highly common and often underdiagnosed comorbidity in HF, encompassing both obstructive sleep apnea, OSA, where the airway physically collapses during sleep, and central sleep apnea, CSA, where the brain temporarily stops sending signals to the respiratory muscles. The pathophysiologic link between sleep apnea and HF is well studied and likely bidirectional. Sleep apnea leads to increased afterload, resistance the heart pumps against due to surges in blood pressure, potentially decreased preload, intermittent hypoxia, episodes of low blood oxygen, and significant sympathetic nervous system activation overnight. This heightened sympathetic tone can provoke myocardial ischemia, trigger atrial and ventricular arrhythmias, and makes managing hypertension more difficult. About 1/3 of HF patients who have sleep-disordered breathing actually have the central sleep apnea type, CSA, which is independently associated with increased mortality in HF, independent of other risk factors. Unfortunately, unlike OSA, where continuous positive airway pressure, CPAP therapy can improve quality of life, decrease blood pressure and arrhythmias, and in some studies even increase EF in HFRDF patients, there's currently no proven therapy that improves outcomes for central sleep apnea HF, beyond optimizing the HF treatment itself. Adaptive servoventilation was actually found to be harmful in one major trial. The role of nocturnal oxygen for CSA is still being tested.
Obesity also seems common, especially in HFpEF.
Yes, obesity plays a complex dual role. It's clearly a major risk factor for the development of HF, particularly HFpEF, and it's also highly prevalent among patients who already have HF. Clinically, obesity complicates the assessment of volume status in both ambulatory and inpatient settings, making it harder to judge if a patient is truly fluid overloaded just based on weight or physical exam. Interestingly, there's a phenomenon known as the obesity paradox in established heart failure, where several studies have shown that overweight or obese patients diagnosed with HF often have a somewhat more favorable prognosis, lower short-term mortality, than those with low or normal body mass index, BMI. The reasons for this are complex and still debated. It might relate to nutritional reserves, different HF phenotypes, or lead time bias, but it's an observed phenomenon. While intentional weight loss through lifestyle changes or bariatric surgery clearly improves quality of life and exercise capacity in obese HF patients and may contribute to reverse ventricular remodeling, its overall impact on long-term survival in this population is still largely unknown and requires more study.
And mental health. Depression.
Depression is incredibly common in patients with heart failure and is recognized as an independent risk factor for adverse outcomes, including increased hospitalizations and mortality, especially noted in older women with HF. The exact mechanisms linking depression and worse HF outcomes are unclear, but likely involve complex interactions, possibly including neuroendocrine dysfunction, like cortisol excess, systemic inflammation, poor adherence to medications and lifestyle recommendations, poor sleep, decreased appetite and nutrition, and perhaps adverse effects of alcohol or certain psychotropic medications. Recognizing its significant impact, the American Heart Association recommends routine screening for depression in all patients with significant cardiovascular disease, including those with HF. While selective serotonin reuptake inhibitors, SSRIs, appear to be generally safe for treating depression in HF patients, large clinical trials have unfortunately not shown that they improve HF outcomes or alter the natural history of the disease itself. The potential effect of other therapies like cognitive behavioral therapy, CBT, or novel approaches like magnetic stimulation on HF morbidity and mortality still requires further rigorous study. The key takeaway is the importance of recognizing and addressing depression as part of holistic HF care to improve quality of life, even if the direct impact on HF progression isn't clear yet. Treating the whole patient, not just the heart pump, is essential.
That's a vital perspective on the interconnectedness of heart failure with all these other conditions. It really paints a picture of managing the whole patient. But finally, for the elite professional, recognizing the signs and symptoms of heart failure is one thing, but making sure it's only heart failure or primarily heart failure and not something else entirely mimicking it or coexisting with it. That seems like another challenge altogether. How do clinicians differentiate HF from other conditions that can present with similar symptoms like shortness of breath or swelling?
This is a critical aspect of clinical acumen. You're absolutely right. It truly separates a basic understanding from a mastery one, the art of differential diagnosis. Many of the common symptoms and signs that strongly suggest heart failure, like dyspnea or edema, can actually be caused by a wide range of other conditions, making the differential diagnosis crucial, especially in the initial evaluation. Clinicians frequently face the challenge of distinguishing cardiac causes of dyspnea from pulmonary causes, particularly since these conditions often coexist, especially in older patients, creating a really complex clinical picture.
So, that shortness of breath, how do you tell if it's the heart or the lungs?
It can be tough. For example, orthopnea, that shortness of breath when lying down flat, while very characteristic of HEF, can also be a well-established symptom in patients with severe chronic obstructive pulmonary disease, COPD, or other advanced lung diseases, often due to altered respiratory mechanics when recumbent. Similarly, patients with underlying pulmonary disease might experience episodes of coughing and shortness of breath during sleep that can mimic paroxysmal nocturnal dyspnea, PND. The key differentiator here, often, is that in chronic lung disease, this nocturnal awakening is usually due to the accumulation of tracheobronchial secretions and is typically relieved by vigorous coughing and expectoration. Whereas in cardiac PND, the patient usually feels an urgent need to sit upright, often feeling like they're suffocating to find relief from the pulmonary congestion itself. That phenomenon of wheezing from bronchoconstriction, sometimes called cardiac asthma, can be a prominent symptom when acute left ventricular failure occurs, especially in individuals who also have underlying reactive airways disease, asthma or COPD.
Differentiating can be tricky, but patients with cardiac asthma are perhaps more likely to exhibit other signs of acute HF, like significant diaphoresis, sweating, and varying degrees of cyanosis, bluish discoloration, compared to patients having a primary bronchial asthma exacerbation.
But what if someone has both heart and lung disease? That must be common.
Extremely common, particularly in chronically ill older patients, many of whom have a significant smoking history contributing to both conditions. In these cases, differentiating the exact degree to which HF-related dyspnea versus primary pulmonary disease is contributing to their overall breathlessness can be nearly impossible based on symptoms and initial exam alone. In these complex situations, observing the response to treatment, particularly effective diuresis, fluid removal, can be informative. If symptoms improve dramatically with diuretics, it points more towards a cardiac contribution. Pulmonary function tests performed after the patient is decongested may also help clarify the severity of underlying lung disease. Cardiopulmonary exercise testing, as we discussed, can also be very helpful in sorting out the primary limitation to exercise in ambulatory patients with mixed disease. And this is where biomarkers really shine. The very low BNP or NT-proBNP level, as we mentioned, can be extremely helpful in excluding heart failure as the primary driver of acute dyspnea in non-obese patients, serving as that powerful rule-out tool that can help steer the diagnostic process towards other possibilities, like a COPD exacerbation or pulmonary embolism.
Okay, so differentiating from lung disease is key. What other conditions can mimic HF, particularly the congestion aspect?
Beyond pulmonary disease, heart failure must be distinguished from other conditions where systemic congestion and edema might occur, but where primary cardiac structure and function are actually normal. The most common example is probably advanced renal failure or chronic kidney disease. Here, the kidneys themselves are the primary problem, leading to abnormal salt and water retention and consequent volume overload and edema, which can look very much like right-sided heart failure. Non-cardiac causes of pulmonary edema, like acute respiratory distress syndrome, ARDS, which is severe lung inflammation often triggered by sepsis, pneumonia, or trauma, also need to be considered in the differential of acute severe respiratory distress, though the clinical context is usually quite different. And finally, it's crucial not to forget common non-HF causes of lower extremity edema. These include chronic venous insufficiency due to damaged valves in the leg veins, primary lymphedema, problems with the lymphatic drainage system, severe obesity itself, or even certain medications like some calcium channel blockers or NSAIDs. These conditions can cause significant leg swelling that is entirely unrelated to cardiac function. It's all about putting together the entire clinical picture, the history, the physical exam, the labs, the imaging, and sometimes the response to therapy to arrive at the correct diagnosis and understand the nuances of each individual patient. Hashtag tag tag outro.
Wow. We have just taken a truly extensive, incredibly detailed deep dive into the world of heart failure. From unpacking its subtle and evolving definitions to exploring the complex interplay of organs and systems, the intricate biological pathways, and navigating the comprehensive diagnostic journey. I feel like you, our listener, now possess a really comprehensive, mastery-level understanding.
And if we connect all this back to the bigger picture, hopefully you can really see that heart failure is almost never just about one single failing part. It truly is a symphony of systems, often playing out of tune, and understanding each instrument's role from the tiniest cellular mechanisms to the gut microbiome and distant organs like the kidneys is absolutely key to both accurate diagnosis and effective personalized management. We've really tried to go from those basic definitions all the way to the incredibly nuanced biological pathways and the full spectrum of evaluation, aiming for that elite professional level of understanding.
Absolutely. And think about some of the key insights we uncovered along the way, like how we busted that common congestive myth to reveal a much broader, more complex reality of HF. Or how the body's own initial compensatory mechanisms designed to help can actually turn against it over time, creating that destructive vicious cycle. And who would have thought, even a few years ago, about the hidden but potentially profound role of our gut microbiome in cardiac health? These are the kinds of surprising facts and deep insights that really elevate your understanding far beyond just the surface level.
And this whole discussion, this deep dive into the systemic nature of heart failure, raises an important final question for you to consider as you reflect on everything we've covered. Given these extensive systemic interactions and the critical importance of complex comorbidities that we've uncovered, how might a truly holistic approach to heart failure, one that aggressively considers and manages all affected organ systems and coexisting conditions right from the start, how might that fundamentally shift future treatment paradigms and patient outcomes? Could that push us even further towards preventing progression or finding better ways to manage this condition long term?
That's a great question to ponder. Keep that with you. We sincerely hope this deep dive has given you not just a wealth of knowledge, but also a powerful new lens through which to view this incredibly complex, challenging, and vitally important area of health. Until next time, keep digging, keep learning, and stay profoundly well informed.